All right. So my name's Hillary Mashburn, and thankfully I'm in my last semester in the RN to BSN program, and this whole entire semester I've been working on this project. It's a proposal project, and it's entitled Improving Patient Outcomes Through Nurse Staffing Reform. And the goal and focus of this project is to enhance patient safety and nursing effectiveness, specifically on our floor, which is a progressive care and urology floor. So the objectives of this presentation are that at the end of this presentation, the audience, which is you, will be able to describe how nurse staffing structure affects patient outcomes, identify key interventions to reduce pressure injuries and patient falls, which are of course the two major medical things on our floor, or really any hospital or medical facility. So, okay, here's the problem. With the high rates of pressure injuries, which is honestly this year it is becoming more of a problem, and also falls, which we've had falls anyway, so it's kind of hard to really say, but anyway, we still have an increased falls regardless. And all of this, the problem is that it's linked to high nurse workloads and charge nurses being assigned to patients, which thankfully here lately we haven't had that happen, but still our high patient or nurse workload is still an issue. This is an issue because not only does it increase cost, it also is increased patient length of stay and harm to our patients. And that comes with the harm of patients like falls, pressure injuries, things like that. And then also, since we're talking about patient safety being a priority, we want to address staffing. So how is it significant in nursing? Whenever we have high patient to nurse ratios, this leads to increased miscare and complications. So just like I said, pressure injuries and falls. And also too, when we get in a hurry and we're supposed to give a medicine that should be like stat, we forget, or we're too busy doing other things. Assigned charge nurses, this decreases response time and supervision. So whenever we have charge nurses who have maybe one patient or more patients, nurse calls on the phone and say, hey, I need your help. And the charge nurse is like, I can't, I'm in another patient's room. And so thankfully, even though we do have rapid response, sometimes we always like to get the charge nurse there too. Staff structure, it affects results, outcomes, morale, and retention. So when we have higher patient to nurse ratios, staff becomes tired, they feel overworked, they feel stressed, and then they're like, I'm moving on. So system level reform urgency is reformed through evidence. So basically through research, it goes to show that it's significant that we have adequate amount of patient to nurses. So going on to evidence-based practice and guidelines, going through research, at least one state is California. They've actually mandated ratios to improve registered nurse hours per patient day and safety, which is good, but we need more states. The national standards like QSIN and ANA and magnet models, they emphasize safe staffing. That's all well and good, but like I said, other states need to implement that so that way we can have safe staffing to increase optimal patient care. So going on the same thing, unassigned charge nurses improve coordination and care escalation. Like I said, whenever they're taken out of patient assignments, they're able to coordinate with staff, see how they're doing, and respond to any kind of patient deterioration. Nurse-led quality improvement projects show that pressure injury reduction. This was just from one study that I'd found that whenever there's adequate, safe staffing with patient to nurse ratios, it helps reduce pressure injuries. So with this literature summary, this is basically all the research articles that I found, and what I've got from it is that decreased ratios, they help reduce and hopefully lower falls, pressure injuries, and miscare. Unassigned charge nurses, it helps improve team function and safety, which like I said, they can really reach out, hey, are you doing okay, that kind of thing. Registered nurse, hours per patient day, it's basically a measurement staffing quality indicator. Consistent support across the recent studies, so basically from studies that I've looked through from 2021 to 2025, it's definitely showed evidence that this is an issue that really needs to be implemented. So the goal of this proposal, there's 4 things that I have, but 2 of them are the main things that will help the other 2 things. So basically implementing 4-to-1 patient ratios, that will help minimize pressure injuries, as well as improve safety, efficiency, and nurse support, with with assigning charge nurse to non-patient care oversight role, like leadership areas, and also supervising the other nurses. So the first intervention is the 4-to-1 patient to nurse ratio. If at all possible, it's emphasized that reducing assignments to maximum of 4 patients per nurse will help patient safety and improve care, timeliness, and surveillance. So basically, if you got 5 patients, but you got another patient that needs your assistance, but you're in another patient's room, it's kind of a lot harder than when you have 4 patients. Same thing with the improving care. It allows better prevention of health-acquired pressure injuries and falls. Like I said, when you have 5 patients and you get so overworked, it's so hard to attend to, making sure that we're turning our patients effectively, making sure we're getting them up, that kind of thing, and basically implementing all the things that we need to do. It helps support staff satisfaction and retentions. Like I said, if you're going to work and you're getting 5 patients every day, you're going to get so tired of it, you're going to say, I'm leaving. And also too, going with the charge nurses not being assigned to patients, they feel more satisfied because, hey, I got somebody that's looking after me, that's helping. So a way we can implement this is to conduct a staffing assessment using acuity and census data. I mean, I know we sort of do this with our charge nurses when they make the assignment, but sometimes looking more into it and saying, hey, look, I know our acuity is really high. We really need the staff, even though what comes to the next one, our budget. So if some way we can collaborate with finance or our budget to explore like different funding to kind of help, maybe if we have to readjust our floating pool to kind of help, lower the cost. We could try this in a 6-week period, see how it does. I know I'm sure I'll do the evaluations, but a way you could do it is see what our measurements and outcomes or whatever of our falls and pressure injuries beforehand, then afterwards do the same thing just to see if there's a difference. Seek funding via patient safety grants. I don't know if we have anything like that, but if we did, that would be something to look into, and then our operational budgets. And then even though in the short term it may increase costs, but hopefully implementing this in the long run will decrease costs with reduction to harm and shorter stays. So now the second intervention is unassigned charge nurses, which is basically making sure charge nurses don't have a patient assignment. It helps focus on supervision, coordination, and mentoring. So this is really good for like our new nurses. If they didn't have, of course, patient assignments, they can say, hey, what can I help you with? You know, because really new nurses are the ones that need the more attention than our, as they call, I can't even think of it right now, but the senior nurses that have more experience. It increases safety oversight and rapid response, which is kind of what we talked about earlier. It enhances team communication and shift management. So whenever charge nurses are not busy with patient care, they can easily communicate with the team about, you know, stuff. Whenever they're busy with their patients, they might say, oh, I forgot to tell you this, and then, you know. So a way to implement this, even though we've been doing a really good job doing it, making sure that the when doing the schedules that they're taken out of having a patient assignment. Provide training in communication and leadership. Might be good just to have a 2-week orientation, making sure that they have the communication leadership skills that they need. You definitely want to involve nurse leadership and educators in the rollout plan to make sure that they're supportive and they're successful. Monitor effectiveness during the pilot implementation. So you just kind of want to make sure that it's working okay. And then going back to, this is the evaluation methods that we can do. As I was talking about earlier, you can compare the health acquired pressure injuries and the falls before the pilot and after the pilot, just to see, make sure, and hopefully that it's working. You want to track RN hours per patient day metrics, collect nurse to patient satisfaction via surveys. This kind of helps to see, you know, if they're satisfied in the process, and as well as patients, because when you have 5 patients are going to be irritable because they're like, I need your attention, and nurses are so overworked that they can't get to that patient in time. Use data to justify full implementation. And then conclusion, the home points are that staffing reform addresses patient harm and miscare. It improves safety, staff report, and care delivery. It aligns with evidence-based practice and national standards, and supports long-term quality and sustainability. So that's the main goal of both making sure that the charge nurses don't have any patients, also with making sure that nurses do not come in and have a maximum of 4 patients if possible. And these are my references. All right, well, thank you for listening. Do you have any questions? What questions can I answer?
So the information you gave with the 1 to 4, is that just in a progressive care unit, or, and do you know in California what the ratios they decided? Is that what they decided on, the max that the nurse can have?
I think some of them was saying at least, I would say 4 to 1, if even less, but on our floor, it's impossible to have less than 3 patients. Mm-hmm. I mean, less than 4 patients. So really they're saying 4 or less patients to nurses.
Do you know what what their mandate was?
I'll be honest with you, I'm really not sure. I think it was probably more so to 4 to 1, but like I said, I'm not 100% sure, and I'm not sure exactly what type of unit, but I mean, literally probably most units, when you think of med-surg, even having 6 patients, that's crazy enough.
Very good. You got a lot of good points in there, though. A lot of things that I've thought about as a leader that, yes, we definitely things that we need to work on. And it's nice to see that actually the research supports what
Mhm.
you are, what I was thinking, what I feel. So it's nice to see that the research actually supports it. Saying, and as you know, pressure injuries and falls have been a huge thing on our unit.
Yeah.
We were talking not too long ago about and this is something with the pressure injuries. The nurses are so busy when they have 5 patients that they miss things. Miss things with the skin, or they don't see this, or don't look up under there. They're going to get back to it, and they don't. And we felt like that has contributed to some of the issues that we've had with our skin, in addition to not having time necessarily to, offload pressure points and stuff. So